In this 27th webinar series of FSIBC, we have chosen the topic of implant-based reconstruction in breast cancer. And we will be basically talking about Indian perspective, Indian scenario. We will have one talk followed by a panel discussion. To give the welcome address, I will now invite Dr. Rajiv Agarwal, sir. He is Senior Director, Breast Oncology at Medanta, Gurgaon. Over to you, sir.
Thank you, Prakshi. Good evening, everybody. On behalf of the Indian Anti-Cancer Trust, I welcome you all to the 27th webinar of the organized by a group of doctors with the name of Focus Studies in Breast Cancer. Over a period of time, there is a lot of attention on the quality of life in breast cancer, including psychological aspects of mutilating surgery of mastectomy. To overcome this, attention is going towards reconstruction after mastectomy, and as we know, there are various methods of the reconstruction. For this meeting, we are focusing on implant-based reconstruction, which is a viable option, cheaper option, and I think reasonably good in the Indian settings. To discuss the topic, we have a very learned speaker and a galaxy of panelists during the panel discussion. They will all be introduced formally by the moderators. To cut my talk short, I invite Dr. B.C. Ashok, who is a senior consultant for plastic and reconstructive surgery in the Manipal Hospitals, Bengaluru. He will be speaking on the implant-based reconstruction. Welcome to Dr. B.C. Ashok.
Thank you so much. Can I share my screen now?
Yes, sir. Sure.
Is it visible?
Yes, sir. It is visible.
Yeah. First of all, thank you very much for team of focused studies in breast oncology. I'm going to today talk about implant-based reconstruction, the Indian perspective and surgical consideration and planning, how we go about doing this reconstruction. To be honest, at the onset, I'll tell you most of my reconstruction are autologous, but I do from time to time do implant-based reconstruction, and the experience I have drawn out of it is what I'm going to speak today. Why is implant-based reconstruction very popular, or why they are becoming popular? As Dr. Agarwal said, it's easy to do, it's easy to learn as well. And from patient perspective, the recovery is faster as compared to an autologous reconstruction. And from caregiver's perspective, there is less time per surgery, there is less strain on resources. So ultimately, even the state gets benefited by doing this implant-based reconstruction. Now, we all know there are two types of reconstruction we do. An immediate reconstruction, this is at the time of doing mastectomy. And in this category, there are situations where we can directly put an implant under the skin envelope. It's called direct to implant method. Or for some reason, we want to delay this reconstruction, we can put an expander, wait for neoadjuvant treatment to be over, and expand that skin and then replace with an implant. So it is a two-stage reconstruction with the first surgery being done at the time of mastectomy. Then we have a delayed reconstruction. And delayed reconstruction can happen for various reasons. If there is locally advanced disease and the prognosis is not good, the oncologists themselves may allow the patient to finish all the treatment available so that it doesn't get delayed, the treatment. And if the patient doesn't want surgery at that time and wants it to be done at a later date because they want to cure the cancer or money constraint, whatever might be the reason, we can always do a delayed reconstruction, which can happen a few months to a few years later once the wound has healed. So in delayed reconstruction, most of the time, if we have to do an implant-based reconstruction, it's a two-stage surgery. First, we need to put expand the native skin, and then place that with the implant later on. We'll talk about that a little later. Now, this is a study done by Dr. Raja Shanmuganathan from Coimbatore. He found, when he did this study, he found out that about 80% of the women were depressed because there was no reconstruction offered to them. And most of them would agree for a reconstruction if money was not a constraint, and if it can be done at a very fast rate or very early. That means the recovery is faster. And most of them in his study, although most of them agreed for an autologous reconstruction, and only 20% of them preferred implant-based reconstruction. We'll come to those reasons a little later in my talk. Now, there is no very specific data to show how much implant-based reconstruction is happening in India, but talking to lots of plastic surgery colleagues, in their practice, less than 5% of it is implant-based reconstruction, and all more than 90-95% is all autologous reconstruction. But if you look at data coming out of UK or USA, in UK 40 to 50% is implant-based reconstruction. In USA, it's more than 75%. And in UK, year on year, it is increasing by 10 to 15% as well. So it's becoming very, very popular in Western countries, and it is not so popular yet in India. But with the advent of the breast surgeons as a breast surgery and breast surgeons as a specialty, there's a recent increase in number of implant-based reconstruction that has been offered and happening in India as well. So what are the constraints we are having in India? There is no implant company directly dealing with implants in India or selling implants. Most of these implants we get through ACE importers, although Mentor and Allergan tried setting up shop in India. Both of them have left now. And if you want to get or procure an implant, it is through importers. So the choice of implants is very, very difficult, both in terms of the size, the shape, the volume. Everything is very, very difficult at this point of time. So what are the implants that are available? The company, Motiva is a US-based company, Eurosilicon from Ireland, Polytech from Germany, Sebin from France. These are the brands that are available right now in India. Mentor and Allergan, they are not being sold now. Coming to the types of implants, we all know you have a round implant and an anatomical shaped or a tear-shaped implant. So the one highlighted with a lighter color are the preferred ones that are used for breast reconstruction. I'm not talking about breast augmentation, in breast reconstruction after mastectomy. So typically anatomical is preferred over round implants. Basically, it gives an upper pole fullness when we do this. And depending upon what is filled inside, either it is a silicone filled implant or a saline implant. And a silicone one is much better as compared to saline. Basically, it prevents rippling, the consistency is much better, and the chances of rupture is much less. And in terms of the cover or the outer shell, what we call, based on how it looks, they are classified into a smooth and nano textured and textured. Textured is not used now. Basically, it is there is a decree against it being used because of the fear of ALCL being developed in such patients over a period of time. So either we have to use a smooth or a nano textured implants, both are okay. The difference between smooth and nano textured is in smooth, there is a higher risk of developing capsular contracture as compared to the nano textured one. And for breast reconstruction, low profile implants, basically the profile defines the degree at which there is projection in the implants. So low profile are very flat ones, moderate ones are intermediate, and high profile are to a given diameter of the implant, how much projection you get out of it. That is what determines low, moderate, and high profile. And this is determined by how cohesive is this gel that has been filled, how hard it is. So higher profile ones are slightly firmer, but they give the best reconstructive goal at the end of it. We can achieve whatever we are looking at. So either you have to use a higher profile or a moderate profile. Don't use a lower profile implants. Now, depending upon the placement of the implants, we can place this after mastectomy. I'm talking. We can place it pre-pectoral, that is in front of the pectoral muscle. It's very easy to do. It's already the cavity has been created. We just need to place it inside. But the main problem with that is, if you plan radiation later, it produces a lot of complications in terms of capsule contraction, in terms of extrusion, in terms of pain and hardening of the implant. And rippling and visibility is another factor we need to consider if it is just under the skin. Capsule contraction, I told, and extrusion is another issue if you put just under the skin. So there are ways to circumvent it by using ADMs or acellular dermal matrix that's being used now, or you can use an LD muscle to cover the front of the implant between the skin and the implant itself. You can also place these implants subpectorally, that is behind the pectoral muscle. What happens when we place this subpectorally is about 1/3 of the outer lower quadrant of this implant is still exposed or still just under the skin. About 3/4 of it is the superomedial part is covered by the pectoral muscle, the pectoralis major. So to cover this exposed part, either we can use something called a dermal sling. I'll show you that surgery, where a part of the breast skin itself is deepithelized and used. The dermis is used as a cover for it. We can also put subfacially using the serratus muscle or the serratus fascia to cover the lower outer quadrant. We can use an LD or we can use ADMs or dermal substitutes. So this is pre-pectoral. It's very easy to do. It's right in front of the people who use this. They say there is no, unlike subpectoral, there is no animation. When the patient exercises or uses the shoulder, there is no movement of the implant, and the shoulder dysfunction is less, and pain and serum are much lesser when you put this implant under in pre-pectoral area. So patient selection in pre-pectoral should be small to moderate breast and people who have low BMI when we are not planning radiation, and they have to be non-smokers. And also you need to be careful that when you have elevated the skin, the vascularity of the skin is good before we plan and put this implant into the pre-pectoral area, because the implant sits directly under the skin. Anything happens to the skin, the implant gets exposed. So, as I said, there are complications that can arise out of putting bare implant under the skin. So, there is a set of acellular dermal matrix that are available, and these are all biological. The left ones are all biological. Human-derived are alloderm and dermacell, it's called. And porcine-derived are Stratis and Braxon. And bovine-derived, it's called Surgiment. Stratis was, I'm not sure whether it's straight away available now, but I had met the guy. He said in 3 to 4 months he's going to arrange the availability of Stratis. Alloderm is still very difficult to procure and need to get it from, import it and then use it. So ADMs are not very, very easy at this point of time. Basically, it contains a scaffolding of only collagen matrix. There is no cells involved. So it is very, very, it's not allogenic at all. We can also use synthetic material like a vicryl mesh or titanium coated polypropylene. I have no experience, but just to complete the materials available to wrap this, I have put it here. So prepectoral implants. This is a Braxon. It is, as I said, is derived from bovine, porcine origin, and it comes like this. It is pre-formed already. It needs to be placed on a table in a sterile environment. Place the implant, whatever implant, round or this thing, and you wrap that and close it with absorbable sutures so that the implant doesn't move out of it. And once it is closed like this, the whole thing is placed behind the skin, and it is anchored so that especially if it is an anatomical based implant, you need to anchor it so that it doesn't move and get displaced. So that's about the ADMs that I have experience with. ADMs, I'll come to that little later, how we have used it and all, but I have not had a chance to use ADMs in the prepectoral area. I have used it as a subpectoral implant with lateral covering. I'll talk to that. So as far as doing the surgery itself, we need to plan, and the planning starts with discussion with the oncologist. What is the likelihood of patient receiving a radiation? That makes a huge difference in how we go about doing this reconstruction. Generally speaking, if radiation is planned, it's not good to do an immediate reconstruction with an implant, especially in the prepectoral space. A thorough history of the patient with history like smoking, history of any skin lesions like scleroderma should be elicited before when we have a consultation, and examination to look out for any infection in the inframammary fold or anywhere else which might cause infection or extrusion of the implant itself. And the most important thing is discussion with the patient. This is very, very important. We need to give all three options to the patient: no reconstruction, reconstruction with implants, and reconstruction with autologous tissue as well, and give the pros and cons to the patient, how it works, and this thing. So ultimately, it's an informed decision making between the surgeon and the patient that determines whether we can go ahead and do an implant-based reconstruction. And at this point of time, the FDA has mandated that a written consent of explaining the risk of ALCL should be done with the patient before we take them for implant-based reconstruction. So the consideration when I see a patient, if I want to do an implant-based reconstruction is the radiation required or not? That's the first thing. And the second thing is comorbidities. If patient has big, large comorbidities like diabetes or hypertension or IHD, which prevents me from doing big, long surgeries, implant-based reconstruction is an option for me. and smoking, at least 6 weeks of cessation should be required. It's not a big problem in Indian society, but especially in metros, it is becoming a factor to be considered. Skin conditions like intertigo, infection somewhere in the inframammary fold should be done. And patients desire what they are looking at. Because if you look at autologous reconstruction and implant-based reconstruction, the autologous reconstruction ages with the other breast. The ptosis, the softness, all that happens like the other breast, which is normal. But if you do an implant-based reconstruction, the breast itself stays upright, little more firmer, and effects of gravity, that is ptosis, is much, much less as compared to the other side. So, but there are good set of patients who say, I don't want this ptosis, you correct the other side as well. So this patient's desire is very, very important consideration when I explain or decide to put an implant for you. And the size of the breast, generally small to moderate sized breasts are ideal suited to do what we call as implant, direct to implant reconstruction. If large breast needs to be reconstructed, we need to explain to the patient that we are going to do something to the other breast as well to match the reconstructed breast. So these discussions have to happen. And availability of donor sites, if unmarried or very, very lean patients who don't have enough autologous tissue, that's another indication for us to do implant-based reconstruction. Now, how to select an implant? This is the most important thing after deciding that you want to do an implant-based reconstruction. So, as I said, at this point of time, a smooth or a nano-textured is the implant of choice. You should not use a normal textured or textured implant. Silicone saline, both can be used. Silicone is slightly better, as I explained, because of rippling and rupture issues. And you can use rounder anatomical. High profile over low profile should be used. And coming to the size, this is very, very difficult. There is no one way of deciding what is the size that you can really put. Now, how to decide? If it is a bilateral reconstruction, it doesn't matter. You can easily talk to the patient and ask them what they're looking at, cup A, cup B, or cup C, and then you can actually take a size that matches. And in secondary reconstruction, again, it's very, very difficult to match the opposite side. So, especially if it's a large ptotic breast on the opposite side, then we need to talk to them that they might require a secondary surgery to the left, other side as well. The biggest problem arises when we do direct to implant in moderate to small breast. How exactly do we choose what is the size we require? I don't have an answer for this, but if you look at one of the ways I do it is when the mastectomy specimen is removed, you can actually measure the volume of the specimen, and if you are using LD on that, you can minus 100 to 150 and use that size implant. If you are using ADMs, whatever volume you have arrived at, you can use that volume implant. That's the only way I have found. Or with experience, you know this is the rough size that you need. So the biggest problem at this point of time is we don't get huge number of implants into the theater. We get 1 or 2 size implants, so you need to make do with these implants, whatever is available for you. So the biggest challenge for me to at this point of time doing implant reconstruction is convincing the patient. They are okay till everything is explained, till we come to ALCL. The moment we say ALCL, more than 90% of them back out of implant reconstruction, implant-based reconstruction. And we also, some of them don't like the idea that there is about 20 to 30% chance of revisions of these implant reconstruction. And as I said, these are the reconstructed breast, there will be always asymmetry. Over the clothing, they look very nice, very symmetric, but once the clothing is not there, when without the clothing, one breast will be slightly higher than the other one. So that's another reason or another big challenge to match both the breast for me. As I said, already availability of size is a big problem at this point of time. You call the supplier and ask, they will say, I want 300 cc, they will say I have 275 cc or 350 cc. So that's very if you want a specific thing, the time taken is about 2 weeks to 3 weeks. So if you plan ahead, you can still get what you want. Otherwise, it's very, very difficult. And also at this point of time, getting one implant, because most of the time reconstruction are done on one breast. Getting one implant is a big problem. And most of them say, no, you need to buy a pair of them. And there is some trouble with insurance approval as well, and sometimes with use of implants. So my indication at this point of time is patients who are not receiving radiation, patients who have bilateral reconstruction, especially prophylactic mastectomies when it's being done for BRCAs, and there are no donor site available. And if the patient insists, I want implant-based reconstruction, and people who have major comorbidity, these are ideal conditions where I say, no, I will use implant for reconstruction. So let me show some pictures of reconstruction. This lady was BRCA positive and she had no malignancy, and she came for bilateral prophylactic mastectomy. And this is the time when we didn't have ADMs. This was completely prepectoral, no ADM used to cover the implant. Directly it's been put. But the advantage of this is that there was no radiation involved. So the results are good, and you can achieve. Actually, we have done a little bit augmentation for her. It's slightly bigger, and she was very happy with it. And unlike when we do augmentation, if you see, the scar is much bigger. For augmentation, we use a very small incisions because mastectomy was done with the inframammary incision as well. So there was a big incision. That's the only telltale sign for her. Another lady, again, pre-ADM era, large phylloids, and we knew she will require radiation. And she was unmarried and she was unwilling, though we could do a diap for her, she was unwilling for any other scars in the body, whether be it diap, the abdominal scar or the back scar for LD. So we went ahead and done a prepectoral implant. And if you see the radiation changes, there are significant radiation changes. The breast itself is much firmer and some creases here and there. But this can improve with time. And also we can improve it with doing some kind of lipofill at a little later date. So subpectoral, now we'll go to subpectoral implant positioning. The disadvantage of subpectoral this thing is there is partial injury to the pectoralis major. So as I said, the implant sits almost behind the this thing, about outer lower quadrant is what is exposed. We need to make a small incision along the lower border and also slightly along the medial border of the muscle. Otherwise, if you don't do that and create a pocket, when there is animation, the implant will be pushed outwards. So this is very much necessary and create a pocket all the way up. So this produces a partial injury to the pectoralis major. And breast animation, when we use the arms or shoulder, there is a movement of the implant. Implant might be much more visible when we do that. And it's been generally told that there is excessive postoperative pain, and incidence of seroma is much higher in subpectoral positioning as compared to prepectoral one. Now, this is how it is done after the mastectomy. What we do is the head end is this side. So along the origin, we incise from lateral or medial to lateral, release the origin of the pectoralis major like that, and there will be lots of small veins which arise. We need to cauterize them, otherwise there will be hematoma. And once we release that part of the origin, rest of the pocket creation can be done with the fingers. That's the only part you need monopolar, just to release the muscle, and then you can just put a finger and you can get good hemostasis, and the implant goes behind this. So once we have created that subpectoral pocket and place, there are 3 or 4 ways of covering the implant which is exposed. One is use of ADM. Second is use of a dermal sling like this, or we can even harvest a small LD and use that to cover that area. Or we can use, this is the pectoralis, and you can use the serratus fascia as well. So 4 ways of covering it. And this is the dermal sling. And dermal sling is possible in patients who have very ptotic breast. So whatever skin we are going to discard from the lower part of the breast, and patient should be willing for reduction in the size. So that part of the skin which we are going to is that approximating it to the muscle. So this helps to. So we can cover most of it, and if there is anything else left, we can also use a small ADM. If the breast is big and the volume is of the implant is small, we can completely cover the lower quadrant with dermal sling, or use an ADM like that. So again, this a long time back, I did this subpectoral reconstruction. I just put it under the fascia of the serratus anterior, and look what has happened. The muscle has pushed both the breast outwards and downwards. Overall, the breast aesthetics is maintained, but big intermammary space has increased significantly. So unless we have a strong pulley here or a hammock here, the implant will migrate or downwards and outwards in subpectoral. So need to be careful when we do this. So the second way of doing this is taking an LD. So this is a secondary reconstruction we have done, and subpectoral large implant, 650 cc implant we have put, and we have taken LD to cover the lower outer quadrant, because the pectoralis muscle was not even covering half of the implant, and the other breast was huge. And this is early post-op, late post-op here, and the patient underwent secondary procedures of nipple reconstruction and reduction on the opposite side to match the opposite breast. So LD is another option for us to use it in subpectoral. So this is the pre-op, this is the post-op, and that's the donor side for the same patient. So unmarried or women who don't have children, where there's no abdomen, you can also use bilateral implants with LD. And this is one such case. Though we tried doing nipple preserving, at the end of it, the nipple was not very vascular, so we need to remove it. This is immediate post-op. Late post-op, the skin pad settles very well over a period of time and settles. And this is the back scars, which they will get if you do an LD. So here, the implants are placed subpectoral, and the LD is used to cover over both pectoral muscle and the outer aspect of the implant. So this another lady who had so-called reconstruction with LD flap, and you can see on the right side the flap was misplaced, and it's not in the right position, and it's not producing any breast reconstruction. It was actually in the axilla, and she unfortunately developed another malignancy on the other side, and she wanted reconstruction to be done and something done for this. So we advanced this flap like this and did an LD from this side. We put 300 cc implants on both sides, and this is the post-op results for her after 4 years, and she's been doing very well without capsule contractures. She doesn't want any nipple areolar reconstruction. So, and that's the plan of harvesting for the left side, the LD that was harvested for her. Another lady, she had breast conservation surgery done on the left side and turned out BRCA positive, and she wanted bilateral mastectomy. So here, and she wanted only implant-based reconstruction. She didn't want an autologous at all. She was very, very clear about it. So here we have done, and she didn't want scars in the back as well. So subpectoral with facial extension onto the serratus anterior. The serratus fascia was used to cover the lower outer quadrant, and this is how she is. Because of the scarring, the left breast is still not very well expressed, but with time and maybe lipofill, we will be able to achieve a better end result for her. So dermal sink, as I said, one of the things that the patient should have is a ptotic breast. Then only the lower part of it can be de-epithelialized and used. So, big breasts are necessary, and patient should be willing to downsize the breast. And non-smokers are the ones we need to use. So this is an old lady, and she was adamant she wanted reconstruction. And she was 72 years, and she wanted breast reconstruction. She was very, very sure about it. So we did bilateral mastectomies, and we used dermal sling like that. And this is the part, the inferior pedicle like skin was, incision was used to approach for the mastectomy. And this whole skin, we removed the nipple areola, and we de-epithelialized this to use and cover a 400 cc implant. And in this case, a small amount of implant was still exposed, and that was covered with an ADM here. And that's the post-op result for her. So ADMs come in different shapes. You get even meshed ones. You can expand and use it, but I feel you should always use an unmeshed one. It gives much firmer a sling and holds the implant in position. And also the amount of scarring that happens is much less. The capsule contracture is much less. It's another unmarried 20-year-old girl who had a large phylloids, and we said we can do a therapeutic mammoplasty kind of surgery for her and remove the tumor and also reduce the other side. And they were very much against it. So we removed the tumor, and it's almost like mastectomy, but there was some amount of breast tissue in the inferior and medial quadrant. Large 6cc implant was put subpectorally, and it was covered. Although on the table it looked like this. This is the pre-op, and this was the post-op. It looked horrible, and we were very, very devastated. But multiple lipofills, we got it into this shape. And last, speaking to the husband, we went and did a reduction on the opposite sides and tried to match to the other side. And this is after 3 cycles of lipofill and opposite breast correction. So secondary corrections will be required, and lipofill is one of them, and opposite breast reconstruction or reduction is a second one, which normally are done for after implant-based reconstructions. Complications, we all know that even in aesthetic surgery, capsule contracture is a major concern. And in these patients, especially because of the extent of surgery that happens, there is always some amount of seroma or hematoma or some subclinical infection and radiation. These are the main causes for capsule contracture. Baker's 1 and 2 are not worrisome, but 2 and 3 are worrisome. We need to sometimes do a capsulectomy, open capsulectomy to correct it and replace it with a larger implant. And implant infection, extrusion, asymmetry, and implant failure. It's known to happen. If you keep the implant for more than 10 years, there is about 15% chance of failure or rupture or leaching that can happen. So if there is any of these, it is better to completely remove the implant, give an interval, and then consider autologous reconstruction for such patients. Although there are some anecdotal reports of doing a lavage or giving an antibiotic wash and putting it back. Ultimately, most of the time, once there is infection in an implant, it needs to come out. So, if you look at the literature, you can find enough evidence against and for implant-based reconstruction. It depends what you want to really quote and say and back up what you want to do. But complications are generally, the acute complications are generally higher in implant-based reconstruction as compared to autologous reconstruction. But the patient satisfaction is also scored very, very high in implant-based reconstruction. In this systemic review, this is what they concluded at the end of it. And if you look at, this is study done by our Dr. Kopikar, and when he has used, overall complications are reconstruction failure are about 20% in implant-based reconstruction. But whenever he has used an autologous tissue like a dermal sling, the infection rates or the complication rates or radiation changes are much less. This is the study that he has come out, and the conclusion he has done is that if you use any autologous tissue to cover these implants, the radiation changes are much, much less. Now, we cannot finish the talk without talking of a risk of ALCL. And now there is another report of squamous cell carcinoma appearing in the capsule of the implants. So there is ALCL, there is other lymphomas that are and squamous cell carcinoma as well. So Peter Cordero, he in his paper, when he has done cohort study of 3,550 or 46 patients, he found out that 1 in 354 patients have developed, are at the risk of developing ALCL in 11 years exposure. That's his study which he concluded. And a systemic review with recent study, this one in 2021, I think. Current risk, it says that in 2011, the risk they said is 1 in 5 lakhs implants. But over the next 9 years, this has been revised many times. And at present, it says 1 in 600 cases, there is a risk of ALCL that is can be developed. And all of it is because of texturization of the implants. If you use a macro textured implant, this is where you will develop ALCL. So even in India, there's a first case reported from Delhi recently of ALCL. So we cannot shy away from this, and we need to be prepared. But the depth is at present about 96 out of, reported and documented deaths are 96. So to conclude, I would say the key to success of doing this implant-based reconstruction is proper patient selection. If you select the patient well, the complications will be less, resurgeries will be less, patient satisfaction will be also very, very high. So this involves a proper planning, a good technique, and intraoperative decision making. So between autologous and implant-based reconstruction, there is not huge difference in terms of complications and patient satisfaction. But if you choose the patient wrongly, that both can change, and both complication rates and patient satisfaction can go down significantly. And with that, I would like to conclude my talk, and I would be very happy to answer any questions if there are.
Thank you, sir, for this wonderful session. We have few questions in the QA box, but I think it's better that if we take them after the panel discussion. Is it fine with you?
Yeah, sure.
Okay. So now we'll move towards the next session, which is panel. And to moderate, I'd like to invite Dr. Vaishali Zambre. Ma'am is Senior Consultant Breast Surgery at RGCI Delhi. Dr. Chirag Jain, he is Consultant Surgical Oncology at Max Vaishali, Delhi. Next slide, please. Now, I will also like to invite the panelists. Dr. Sanjay Mahindru, he is Director Plastic, Aesthetic and Reconstructive Surgery at Medanta, Gurgaon. Dr. Vipul Nanda, he is Chief Cosmetic and Plastic Surgery, Aesthetic and Reconstruction Surgery at Artemis. Dr. Anupama Mane, Consultant Breast Surgeon at Ruby Hall Clinic, Pune. Dr. Vipin Barthwal, Associate Director, Oncoplastic and Reconstructive Surgery, Max Hospital, Vaishali. Dr. Gautam Sharan, sir is Medical Director, Radiation Oncology at Jawaharlal Nehru Cancer Hospital, Bhopal. Dr. Shashank Chauhan, he is Assistant Professor, Plastic Reconstructive and Burns Surgery, AIIMS, Delhi. Over to the moderators.
Thank you, ma'am.
So while Dr. Chirag is actually uploading his PPT, I'm actually going to say that the questions which are there in the Q&A box are already going to be asked during the panel discussion. So those who have actually asked those questions, be assured that all your questions will be answered during the panel discussion as well. I'm sure there are going to be a little bit of overlap between Dr. Ashok's talk and the panel, because there are a lot of things which he has already covered. But at the same time, we are going to be, getting the answers from a different set of, plastic and reconstructive surgeons. So we'll be happy to have their perspective as well. So let us, get ready and start the panel discussion. Over to you,
Yeah.
Dr. Yeah.
Thank you, ma'am. Are my slides visible?
Yes.
Okay, thank you. Firstly, thank you to Dr. B.C. Ashok, sir, for such an enlightening talk. He's practically cut the panel discussion maybe to half the time with his elaborate talk and such great representation of all the cases that they have done. Thank you so much, sir. Welcome to all the panelists, and thank you for taking out time from your busy schedule for this talk. Welcome all of you. We will be having this implant-based breast reconstruction case-based panel discussion. So let me start with the history. So this is a 31-year-old premenopausal lady who presented to us with a right breast lump in the outer quadrant of the right breast since 2 months. There was no history of any pain, nipple discharge, any other swelling or lumps in the same or the opposite breast. She was married with 1 child, which was a normal vaginal delivery. No family history of cancers. She was a non-smoker, and there was no history of any previous surgeries or scars on the abdomen. Coming to the clinical examination, the right breast, we were able to palpate 2 separate lesions in the right breast. One was at 9 o'clock position, which was 2 centimeters away from the nipple areola complex, which was about 2 into 1 centimeters in size. And then there was another one of size 3 into 2 centimeters at 7 o'clock position, which was about 4 centimeters from the nipple areola complex. There were few mobile palpable axillary lymph nodes in the right axilla. The left breast and axilla was normal, and the supraclavicular foci was normal. Coming to the investigations, the ultrasound of both the breasts was done, which showed a right breast lesion, which was 13 by 8 mm irregular hypoechoic lesion at 9 o'clock position, and another lesion which was in the lower outer quadrant, which was about 24 into 8 mm in size. Axilla showed few rounded lymph nodes with loss of fatty hilum. The left breast and the axilla showed no abnormality. So the right breast had 2 lesions. The first lesion was graded as Byrod's 4C, and the second one as Byrod's 5. The left breast was Byrod's 1. So the ultrasound guided conidal biopsy of both lesions from the right breast was done, which was showing infiltrating ductal carcinoma grade 2 from both lesions. She was also triple positive with Ki67 of 12 to 15%. And the ultrasound guided FNAC from the right axillary lymph node was also positive for malignancy. She also underwent a whole body PET CT scan, which showed multifocal ill-defined FDG avid nodular lesions in the upper and lower outer quadrant of the right breast, with few FDG avid right axillary lymph nodes and no other any FDG avid lesion in the rest of the body. The genetic counseling was done and testing was done. She was BRCA negative. She received 6 cycles of TCHP-based neoadjuvant chemotherapy, and reevaluation was again done with a PET CT, which showed good response in both the breast and the axilla. Surgical options were discussed with the patients, and patient opted for a mastectomy and was keen on reconstruction. Ma'am?
Yeah. So I would like to actually begin with Dr. Anupma. Dr. Anupma, I'm sure you're going to you face such a situation clinically, day in and day out. So in a patient who presented with positive nodes, despite the fact that she has responded to chemotherapy, but I'm sure she is going to be offered axillary dissection and will receive radiation. So in such a situation, if the patient is keen on primary reconstruction, how comfortable will you be offering reconstruction immediately? And if yes, then what will be your choice?
So I'm very comfortable offering reconstruction definitely to such patients. She's a young lady, even though she's node positive and will receive radiation, I think she deserves a good reconstruction. Whether it is primary or secondary is also based on the patient's choice as well. And what I have seen in my practice is most of the patients opt for primary reconstruction. Delayed reconstructions are very, very few. So definitely I'll be counseling her for both implant and the autologous tissue reconstruction, the pros and cons of each. In fact, there are several consultations that are held with this. And then we come to a shared decision regarding which one is best for her. And of course, her size of the cup and the ptosis and all those technical factors are also important in deciding which reconstruction.
Right. So moving on to Dr. Nanda, I would in fact want his opinion as well. In case if the patient has given that decision-making power to you, if she says that, doctor, I will do whatever you want to do with me, what will be your choice in such a situation when the patient is likely to require radiotherapy?
I think if the radiotherapy is planned, then definitely an autologous would be a better option. I would think so.
Okay.
But of course, decision is made by so many people together.
So does that mean that implant will be a total no-no for you in case if
Not
she's
really, no, just autologous is a preferable thing.
Is a preferred.
I mean, I feel so with my experience.
Yeah. Dr. Mahendru, your perspective?
Yeah, so I think radiation is a big key factor here. But over a period of time, we have seen that implant-based reconstructions are also doing well, even in patients who are bound for radiotherapy. So I think the decision is lies with the patient. But first of all, most importantly, a primary reconstruction, absolutely primary reconstruction in such patients, and offer them autologous as well as implant-based reconstruction, discussing the pros and cons. Yeah, we tend to, because our experience with implant-based reconstruction is not much, and it's only been a couple of years that we've been doing. I think as we get more comfortable with implant-based reconstruction, I think we will offer it more to patients who are also offering, going for radiotherapy.
Right. And Dr. Vipin and Dr. Chauhan, do you feel the same?
Ma'am, actually, thank you, ma'am. It actually also depends on the size of the left breast. How is it? How big is it, and what kind of ptosis the patient has? And yes, I agree with Dr. Nanda and Dr. Mahendru that autologous tissue is more preferable in this patient. And yes, it depends on whether the patient wants implant or not. It also depends on the cost factor, whether the patient is poor or is going to a private clinic, because as I'm in a government hospital, cost is a major issue to all the patients that come to AIIMS.
Dr. Shashank, we are going to talk about the factors in decision making. However, I just wanted to ask you about your take on use of implant when the patient is likely to require radiation.
Yes, we would prefer autologous tissue over implant.
Okay. And Dr. Vipin, is that the same?
Yeah, the first preference will be autologous. But again, despite that, we have done a couple of, in fact, more than that cases. And surprisingly, they are doing good. Even after radiation, almost a couple of years now. Okay. So, but still, the first preference will be in this patient will be an autologous one. Autologous. Yeah.
Okay. Over to you, Chirag.
Ma'am, this is for Dr. Anupama, ma'am. So, ma'am, does neoadjuvant chemo affect the surgical outcome in terms of desired cosmesis for the patient with the fibrosis, post chemo fibrosis and everything?
So yes, neoadjuvant chemo does affect the outcome in terms of increased risk of complications, actually. So any patient who's received this, we always take it with a pinch of salt that there is a higher risk of having seromas and other complications, including infection or even implant extrusion and all that. And that will be a factor in choosing the kind of reconstruction that we do for such a patient.
So would you change your plans of reconstruction based on whether the patient has received NSCT or would receive adjuvant chemo?
Yes, I think a little difference may arise because of the neoadjuvant and adjuvant chemo. Yes.
So what kind of reconstruction is more preferable in patients who have received NSCT?
So autologous obviously is a better choice again than the implant based, because whatever said and done, the implant is, yeah.
Right. And Mahendra sir, your comment. Yes, Ashok sir, please. Yes, sir.
Sorry for interrupting.
No,
basically, even when we do autologous reconstruction in patients who have received neoadjuvant chemotherapy, the complication rates are higher, as Dr. Vaishali said. Seromas and even episodes of bleeding, hematomas are much higher, and the vessel quality is different, especially the veins. We have seen to be thinner walled and much more friable than patients who have not received it. So it is a challenge when there is neoadjuvant or adjuvant chemotherapy that has been given, both in autologous and implant-based reconstruction. So you have to be extra careful in your surgical techniques to overcome this.
Thank you, sir. So these are the few clinical photographs of the patient. So coming to what are the relevant examination findings, as Ashok sir had already discussed, coming to the bra size, the cup size, and a little about the base diameter. Sir, I would like to start with you, Dr. Sanjay Mahendra, sir.
So besides all these, measurements which we take on the affected breast, it is also important to note what is on the other side, because we are trying to match the size, the breast which is not being affected. So I think the measurements on that side are also very important. The grade of ptosis.
Right, sir. And
yeah, please.
Yes, sir. And could you enlighten us about a little for our audience about the base diameter, what exactly it is and how do we measure it, and how it helps in the recon planning?
See, base diameter is the, when you measure the footprint of the breast. So if you move the breast medially, there you get a fold here, which is the medial one. And similarly, the anterior axillary line is the lateral one. So we measure this base diameter. This is the breadth of the is the width which you measure, and then you have to subtract the soft tissue thickness, which is generally 1 centimeter from this measurement, and that will give you the base diameter of the breast. This is what you want to reconstruct, and especially with implant based reconstruction, you tend to match, even if you're putting expander on implant, you tend to match the base diameter of the existing breast, so as to get a good result.
Dr. Vipulnanda, sir, so for the desired ptosis, how exactly do we plan, and what kind of reconstruction is more suitable when a patient has an opposite ptotic breast?
Yeah, so I think Dr. Ashok has mentioned all those things very nicely, but basically if we are using an expander, we would overexpand like much more so that we have that extra skin available, so that we get the ptosis. And also, if we are using an implant, then we can use an additional LD muscle to get that additional skin and create that symmetry. And as Dr. Ashok said, and all of us know, the other breast may need a procedure to get the matching.
Right.
So these are the few things.
So opposite breast reduction surgeries are not very uncommon when we are doing reconstructions for breast cancers.
Often the patient may not agree at that time, but they may sort of accept it gradually. Yeah.
Later, at a later stage.
Yeah.
Dr. Mahendra wants to say something.
So,
yes.
So when we have a ptotic breast on the other side, which we're trying to match, I think an autologous reconstruction again will take precedence.
The front sheet.
And if you are doing an implant-based reconstruction, then you have to actually, inform the patient and guide her that she is likely to need more symmetrization procedures to match the reconstructed breast, which is implant-based reconstruction.
Sir, BC Ashok, sir. Yes.
One of the things that you can do even when you're doing an expander, as Dr. Nanda said, that you can overexpand and also leave it for a longer period. At least 6 months you leave before you exchange it for a prosthesis. And when you exchange it for a smaller prosthesis, you get a bit of ptosis. So you leave that expander for a longer period. So all the capsule, everything matures and gives that ptosis.
Right. Vipin, sir.
same. Dr. Ashok already said both the points. So we leave the expander for a longer time and choose a smaller implant so that it is not very tight and ptosis is better. But still, with radiation, things will be difficult, no doubt. That is, the normal ptosis may not be that great, that good. Yeah, thank you.
Well, yeah.
The question is for all the plastic surgeons there. When we are talking of achieving ptosis, one is that how does, say, prepectoral versus a subpectoral placement compare in terms of achieving some degree of ptosis? And secondly, the bottoming out that happens, how does it affect the ultimate development of ptosis? Or so do we sort of expect some degree of bottoming out and factor that in?
Anyone, sir, Dr. Sanjay Mahindra, sir.
So basically, can you repeat the question, sir, about the ptosis?
So one was whether a prepectoral versus a subpectoral positioning, that choice would be affected when we have a slight ptosis. And secondly, how does the bottoming out, which happens over a period of time, affect your planning in the beginning?
So I think for ptosis, a prepectoral implant is likely to give you a better ptosis because when you do a subpectoral muscular coverage implant, you are likely to use a scaffold for inframemory fold, coverage and a sling. So that holds the implant there. And so a prepectoral is likely to, give you more ptosis. And bottoming out, I'm not sure, how are you going to do that? But definitely with the use of a scaffold ADM or a dermal sling, it is likely to support the, implant better and avoid this bottoming out, which you can see sometimes.
I would just like to say that, to prevent this bottoming out, LD is a very good option with implant. LD gives a really strong support and it's very good. A good closure with the IMF will support it very well, along with increasing the ptosis in a prepectoral placement.
So, Goel sir, that is the way we usually do it. We create a loose pocket for the implant placement or expander and suture the LD all around the IMF, the lower, so that we have a good support. So bottoming out will be taken care of by suturing the LD muscle below, and the implant will be under the LD muscle. So, and it will be a loose pocket. So most of the time we don't place the implant under the LD. It will be under the pec. It will be prepectoral, but under the LD flap.
I'm sure with the cost and non-availability of ADM, LD is a wonderful option to cover the lower pole of the implant and prevent this problem later.
Because especially in these patients, which we expect the radiation chances are higher, so we can have a good night's sleep at least with a good LD cover. Because leaving it just under the skin and expecting the radiation will be there, I mean, we might be waiting for a disaster. So having an LD is must in these cases.
Right.
Over the implant.
Some degree of some degree of ptosis, and I think bottoming out is desirable, right? We want to match it to the other side.
Yes, of course.
So I think one point I want to bring in here is that, being in a developing country like India, and where we have issues with ADMs. So, an implant-based reconstruction actually becomes a hybrid reconstruction. That means you're using autologous tissues also, because most of the times you're using LD. So it is not actually a pure implant-based reconstruction or an alloplastic reconstruction. Correct. I would say it becomes more of a hybrid. So I think the more, whenever the ADM is available, then I think we can, get the LD factor out and use ADM more often to use in our implant-based reconstructions.
I think Ashok sir wants to share.
So the bottoming out part has, I'm not sure who mentioned, recreating the inframemory fold nicely, so that most of the time when you do mastectomy, there would be little violation of this inframammary fold. It would have gone down.
Yes.
So you recreate that inframammary fold with Vicryl stitches and choosing a proper size implant. If preoperatively, if you measure the distance between NAC and the inframammary fold and use an implant which has got a similar radius, so that will help to prevent a certain, I mean, not completely, but also helps to prevent bottoming out.
Yeah, thank you, sir.
Yes, ma'am, one thing more, I would like to ask that bottoming out, that term is usually referred to reduction mammoplasty patients and not for breast reconstruction patients, because most of the patients in which the nipple area complex has been removed as a part of the mastectomy will have time to reconstruct the nipple area complex at a later date once the implant is there or the autologous tissue is there, so that we can then pinpoint the exact location of the nipple area complex. So there will not be any effect of bottoming out, so to say, that is present there.
I think what Dr. Goel wants to emphasize by saying bottoming out is if we don't have a good support at the lower end for the implant, then that implant, like a glandular ptosis, might, be appreciated. Then, right, sir?
So,
sir? That's what
outward and downward migration of the implant.
Yeah.
Downward migration of implant.
Yeah.
And what Dr. Shashank said about nipple areola, I believe symmetry would be an important consideration in placing the nipple areola, and it may not be just, you do not want a asymmetric nipple areola. So.
Yes, sir.
Also, I have this query, sorry to interrupt, query about delay of nipple areola complex. I read about these things. In implant-based reconstructions in prophylactic mastectomies, for example, the Superstar model got it done, Angelina Jolie. In that case, there was a delay procedure was done a week prior to mastectomy before the implant-based reconstruction was done. So I just wanted to know the views of the panel, about delay of the NAC before the prophylactic mastectomy.
So, Dr. Ashok, would you like to take that?
So it depends on the size of the breast. If the breast cup A, cup B size, I don't think you need a delay of delay phenomenon required for this thing. But if you see a cup C or a very ptotic breast, maybe a delay of chances of survival are much high. So, but in very ptotic breast or cup C, ultimately you're not matching the other side. You're going to make it smaller. So a nipple reconstruction would be a better option than to retain that nipple areola. In any case, it would have lost its sensation when we do this. So that's my take. If it's a small breast, you try and preserve it. If it's a large breast, better to reconstruct nipple secondarily.
Yeah, I think we'll move on. Dr. Chirag?
Yes. So, Dr. Anupama, ma'am, your thoughts on whether it would be a classical, complete skin paddle MRM, classical one, skin sparing mastectomy and nipple sparing mastectomy is your experience, and could you please share with us?
So in this patient particularly that we are discussing, first of all, I would like to know the distance of the tumor from the skin. So whether we can conserve the skin or not. Yeah. Distance from the nipple you've already mentioned is 2 centimeters and 4 centimeters. So I think we can safely spare the nipple areola over there. But whether skin can be spared or not will depend upon the distance of the tumor from the skin.
Right. So this was almost in the mid depth. Yeah.
Yeah. Right. Yeah, depth. So that will guide whether we are planning a skin sparing or a nipple sparing or whatever MRM.
So, sorry, Dr. Anupma, I just wanted to ask you whether the choice of axillary procedure will make a difference, especially if you are doing a sentinel node biopsy versus axillary dissection. Will the choice of doing implant-based reconstruction change in decision making, especially if the patient is undergoing sentinel node biopsy upfront? Will you be happy to offer her direct implant or whatever versus a person who is undergoing ALND? Why I'm asking is there any difference in terms of complication rates if the patient is undergoing ALND plus implant versus sentinel node biopsy and implant?
So with sentinel node biopsy, obviously, the vascularity of the lateral part of the skin of the chest is much better preserved rather than with axillary dissection. You are cutting a lot more smaller vessels over there.
Yeah.
That is the only point that I can think of, apart from the fact that ALND will also later on, convert to a radiation for the implant.
Yeah.
So not significantly. I won't say it will change my plan significantly, but I'll just have to be very careful about the vascularity of the skin.
And in terms of seroma and the complications,
seromas obviously are more with axillary dissection. Yes,
Yeah.
obviously. Yeah.
Right. Yeah.
So she underwent a right skin-sparing mastectomy with the axillary lymph node dissection. The final histopath show the foci of residual carcinoma measuring 2 mm and lymph node 0 out of 16. So I would like to first begin with Ashok sir. Sir, what are the options of reconstruction that we have in this patient?
Being a plastic surgeon, I would offer them first autologous
reconstruction. Yes, sir.
It gives better satisfaction to the patient in terms of how, with age, how the breast matures and matches the other side, and the tummy is also taken care of. And to be honest, lots and lots of patients who undergo higher flap, they are also happy with the way the tummy looks after the surgery. So my choice would be to do
autologous
reconstruction. And there was axillary dissection was done, right? Complete.
Yes, sir. Axillary dissection was done, and we also have to remember that she was also a candidate for a post-mastectomy RT.
Okay. So now, so if we have done axillary dissection, the DIAP also gives an opportunity for us to look at transferring some vascularized lymph node also into the axillary area, along with the DIAP as a hybrid flap.
Yeah, that's right. But if the patient is not happy for autologous reconstruction, then and she insists on implant based, then what will be your take? Anyone for that matter, will it be a 1 stage or a 2 stage, or will it be a direct to implant or expander first? We'll begin with Dr. Nanda.
Yeah, so I would prefer an implant with an LD flap. I mean, if somebody doesn't want a tram or a DF, so implant with the LD works well, and LD alone may be sufficient. In fact, if it's a very small breast, but that depends.
Yeah. So you, I mean, even if it is post-op radiation, you will go for direct implant rather than 2-stage procedure.
Yeah, single stage is preferable.
Single stage. Dr. Mahendru?
See, because we already know that she's going to have radiotherapy, I think I would put my bet on a 2-stage reconstruction. So put in an expander first, and then do implant exchange after the radiotherapy is over.
Okay. Dr. Chauhan, Dr. Bipin, what will be your choice? 1 stage or 2 stage?
I'll look at expander, the LD with expander. I mean, expander the LD as a first stage, and then maybe once she's completed her therapy, then after 6 months or so, because as Dr. Ashok said, to get the good doses and all, we over expand it and then do the implant exchange at a later stage. Safer approach.
And
Dr. Expander would be a 2-stage procedure. Would probably be my preferred choice. If given a choice, that if the patient agrees that sure, yes, I will like to cover the expander with the LD flap, and then over expand and then exchange with the implant.
Okay. Dr. Chirag?
So, as already discussed, there are options of both immediate and delayed reconstruction. The preferred choice would be an autologous reconstruction, but just in case the patient is candidate for wants implant-based reconstruction, then how do we decide the plane of the implant best suited to the patient in a particular patient? Dr. Vipul Nanda.
I think the tissue is good. The skin quality is good. I think under the skin is good enough.
Gotcha.
But yeah, I mean, depends on the quality, how thin the skin is, how good quality it is. If that looks good, then the implant can be placed under the skin.
So it's just the thickness of the skin that we are looking at before deciding on what.
And the vascularity. What, I mean, you've done a mastectomy, you should be able to assess what are the skin vascularity at the edge.
Vipin sir, any thoughts regarding the plane of the implant that is best suited for the patient?
If you are doing LD, then I don't think it's necessary to place the implant under the pec also, because then there are too many variables. We have LD above, then pec major down. So it will be pre-pectoral and under the LD muscle. And obviously the choice with radiation setting will be an expander first. But nowadays there is during COVID time, there was a practical problem that we are not getting expander easily. And for quite some time, for almost more than a year, we couldn't get any expander at all. That time we had to, do a direct implant, and the patients are doing fine. But again, expander followed by implant, second stage is what I'll prefer in a radiation patient. The patient who is expected to.
So, sir, what is the ideal time you would actually want to exchange an expander with an implant?
Minimum 6 months if radiation is there.
Yeah, if radiation is there. So because in patients who are candidates for who are going upfront surgery without a neoadjuvant therapy, they have a lot of time for the chemo first and then radiation, and then maybe go for the exchange of the expander. But for patients who are already undergone neoadjuvant chemotherapy, they have very little time from the surgery to radiation.
Yeah.
So does that change plans a bit?
I think around a month or so of radiation therapy will be there. Then we have to. It depends on patient to patient how the skin quality is after radiation. Like Dr. Nanda said, how is the thickness of the skin? If it is thinner skin, then we have to wait for some time.
There have been a lot of papers which say that when the patient has undergone primary expander-based reconstruction, then after the chemotherapy, and before the start of radiation, the patients undergo, the changeover from expander to implant, and then implant is irradiated. Dr. Ashok, is there any experience similar?
No. I was about to comment on that. So. Yeah. If there is a patient is going to receive adjuvant chemo first and then radiation, if you have enough time, you have time to expand the cavity, and either you can place an implant and then give a radiation, or you can irradiate the expander only and then wait for radiation changes to go away. For 6 months you can exchange it for an implant. So it depends on when you are receiving the radiation. If the radiation is planned later, you expand in the intermediate time. You could do that. But I have no experience in that. So that's a window period which you can use.
Yeah. Yes, sir.
I just wanted to ask about this only. So then the patient who's got neoadjuvant chemotherapy, the expander has been placed. And generally the radiation is planned, say 3 or 4 weeks after the surgery. So what is the protocol followed for what happens at the time of radiation? Do you deflate the expander a bit? And what about the further expansion protocol? Does it happen later on? So maybe Dr. Vipin, Dr. Ashok, and any others, if they can comment.
I just wanted to ask Dr. Ashok that only, sir. Usually, since we are same team, we usually follow the patients on regular basis. So what I do is I call them during the radiation also, weekly 10 days, and see them if I need to deflate the expander in between. So I usually do that. And if the skin quality is good, I keep it expanded like it was during the surgery. So in 1 or 2 cases, I had to deflate the expander because there were significant skin changes. Dr. Ashok sir, what do you say about that?
Absolutely.
You need to always deflate, or do you keep it?
No, whatever we have inflated, we keep it unless there is a local problem with the skin. And generally, after finishing the radiation, while the radiation is happening, the radiation oncologist will not allow us to use any kind of creams or moisturizer onto the skin. So the skin becomes very dry and very kind of stiff. But once the radiation is over, if you start using moisturizers and little massage, in about 6 to 8 weeks time after the radiation, you can start re-inflating the implant. But you need to be a little slower than what you would do in a non-irradiated patients, and be careful about how much you put every time they come for insufflation of these implants. I mean, sorry,
let's hear Dr. Sharan also. He has a vast experience of irradiating implants. Yes, sir, please.
So, am I audible, Dr. Vaishali? Good evening.
Yes, sir, you are.
So, Dr. Ashok, the paper that he has referred of Dr. Kopikas, I think I was the radiation oncologist who had done all the radiation to all these patients.
Okay.
What we used to do is, it was around, later on he changed to oncoplastic breast surgery and we stopped doing this implant based. But way back from 2011 to 13 or 14, we did some around 40-45 odd cases. So our protocol was to over-expand the expander, over-inflate the expander. Just before the radiation, he used to deflate it a little bit, because the radiation is going to cause some fibrosis and tightening. So you need that extra skin. And once the radiation is over, then he used to start expanding it again. And at a later date, this expander was changed to an implant. So radiation was always done with an expander and not with the implant in our cases. And as you had mentioned earlier, Dr. Ashok, that later on he changed to using lower dermal sling, and then we found that the incidence of adverse effects was much lesser than what with the radiation with expander.
So is your protocol the same even now, Dr. Sharan?
We don't find any cases now. There are more of autologous implant reconstruction rather than that implant-based reconstruction. So
right.
For last 3-4 years, I think I have not done a single case of implant-based reconstruction.
But is that because of patient choice or the availability of implants or some other reasons?
This could be a mix of factors, I think. The surgeon's preference, the patient's choice, and the availability, all three comes into play. And later on, because primarily when we used to work together, my surgeons have changed to more of an oncoplastic breast surgery, and rather than doing this implant-based reconstruction.
Right. Thank you.
So may I just come in?
Yes, yes.
See, if we look at the current literature and compare that, tissue expander or a two-stage reconstruction with radiotherapy and a direct to implant with radiotherapy, I think the patient outcomes are actually same.
Okay.
So there are no differences in patient-reported outcomes. It is only when the surgeon-reported outcomes are seen, the aesthetic outcomes are better in an expanded patient. But the patient-reported outcomes in literature, actually, I don't have vast experience, but the patient-reported outcomes in literature are actually the same. So it does not matter whether you're doing radiation to implant or to the expander first. The outcomes are actually same. This is the current literature evidence.
Okay. So that is the reason you would be happy doing direct to implant plus LD and then irradiate.
No, I didn't say I would be happy. I'm still worried about it because radiotherapy is a big factor, But this is the correct people who do lots of these things. They know that the radiation to implant directly would have a similar outcome. In fact, they would go on to explain their patients that their outcomes will be similar to a two-stage procedure. They will tell their patients who are undergoing one single-stage operation that their outcomes are likely to be same as a two-stage operation.
Right. Dr. Vipin, yes.
Yeah, ma'am. This moment, I must congratulate and compliment our radiation oncologists, because initially, like every plastic surgeon is worried about radiation and implant and everything. So initially I was worried, but over a period of time, I've been seeing these cases. Either the planning is so well, I haven't seen too much of a problem with implant, and radiation planning is quite well, I think. So they need to be complemented. Our radiation oncologists are
I'm sure.
Yes.
Yes.
So even forcefully, like I said, for a good 1 year, we can't get any expander. You must be remembering we were doing direct implant, and but luckily, surprisingly, the results are okay. Like Dr. Sanjay said that maybe the results are same with the expander plus later implant or single stage.
Yeah.
But again,
so the direct comparison, the results have been reported to be similar in the 2-stage versus 1-stage, and then radiation. There have been, published papers. So, Dr. Anupma, is that the same opinion on your side?
So frankly, I feel that, when you tell the patients about 2 surgeries, many of them are not very willing for it. So patients by themselves would choose a direct to implant surgery.
True.
So that's what happens most commonly in our scenario. And they want a primary reconstruction because it can be covered by the insurance companies with the same issue. So they just want one surgery, one complete surgery, and that's it.
Yeah. Dr. Mahendra, you wanted to make some point?
Yes, so I think also with advances in radiation oncology and giving radiation in a prone position, which has less deleterious effects on the implants. So I think with the advances in radiation oncology, definitely, I think the more and more direct to implant reconstruction would be seen in the coming years, I think.
Yeah. Thank you, sir.
Right. So, sir, coming back to the point of the plane of the implants. So what I would like to just know from our plastic surgeons, what are the advantages and disadvantages of each, the subpectoral, the prepectoral, and then the dual plane implants? To begin with, Mahendra, sir.
See, so there are 3 planes. One is the total submuscular coverage. So total submuscular coverage is when you use pectoralis major and either serratus, fascia, or serratus. So the outcomes, aesthetic outcomes, actually the poorest with the total submuscular coverage, and the patient also has a lot of postoperative pain. I think the best would be a dual plane when you release the pectoralis fiber and then cover the inferior lateral part with either LD or an ADM. But yes, lately the prepectoral placement has also been good, because prepectoral placement, there is less pain postoperatively. The animation which is seen with the pectoralis fibers when you put it under the muscle is also very less in prepectoral placement.
Ashok sir has already enlightened us with the slings and ADM. I would like to, ask maybe Mahendra sir first. Share your experience with slings and use of ADMs.
See, ADM we have used only in 2 patients, and that too we had to actually procure from Europe. It was not available here, but now I hear that yes, in few months' time it is going to be available. So we have some experience with the dermal slings, yes, and they do all right. And but generally, we are using a hybrid model where we use the LD muscle, which we recreate the inframemory fold, and then suture the upper part of the LD with the lower part of the pectoralis, release pectoralis muscles, so that we have a total coverage of the implant or the expander.
Dr. Anupma. Hey, Dr. Anupma wants to make a point.
Yes, sir.
So we have published 2 papers on this. One was a comparison of LD with implant versus implant with the lower pole coverage with ADM. So by ADM, I mean the biological matrix that was available in India a few years ago. And later on, they became a shortage in last few years. So we had used that, total about 44 patients. They were divided into 30 and 14. And what we found that LD with implant was a much safer option, better cosmetic outcome, less complications. The cases where we used the biological matrix, we had a 35.7% complication rate. That was extremely high. So as a result, after that, we stopped doing the biological matrix, the lower pole coverage, and obviously shifted more towards the LD flap. So that's a direct comparison study between the LD implant and the ADM that we have used. Now we are not using this matrix anymore, though it is now again available in India.
And how about the Vicryl mesh? Is there any experience?
No, I haven't used the Vicryl mesh.
Okay. Dr. Chauhan, we heard that in Holiday Institute, Vicryl mesh experience has been quite a significant one. Do you use
not in breast reconstruction?
No, not in
Not
that.
in breast
Okay.
reconstruction.
Okay. So anyone else who has experience with Vicryl mesh?
No.
Okay. I think Dr. Gautam Sharan is in a hurry to go. Can we move on to the radiation related questions?
Right.
And we'll come back.
I'll just hand it over to Dr. Prekshi then.
Yeah. Dr. Prekshi, over to you.
Yes, ma'am. So, sir, are you there, Dr. Gautam?
Yes, I'm here.
Yeah. So we have already taken the surgical oncologist and the plastic surgeon's perspective regarding how they are happy with the timing of whether it is immediate or delayed, whether it is autologous or it is implant based. So what is your experience? Like earlier you were doing implant based and now you are doing oncoplasties, RT in such cases. So what is your experience in which cases, which is a favorable profile?
So number one, I have limited experience and my experience is limited only to the cases that we did. And that was, that's something called immediate delayed reconstruction. You irradiate the expander and then the implant is placed at a later date.
Okay.
Irradiating an oncoplastic breast and implant-based reconstruction are two different things. So you cannot just compare. The third thing is I have no experience irradiating an implant. So let me be very honest. If you your second question is, should we include the implant in the RT field? So I don't know. Because ideally, it is said that you will have to include the implant if it is in the pre-pectoral position. Okay. If it is the subpectoral one, then you can leave the implant. But if it is the pre-pectoral, you will have to include, and the chances of capsular contracture and extrusion are much higher in that case. We irradiated all the cases in 40 gray 15 fraction schedule, so it was all hypofractionated and the results were not bad. I think you theoretically expect higher late toxicities, but we did prompts, we did, initially we did some breast questionnaires. Later on, we changed to Grabe's questionnaires and the results were not different. Actually, we published a paper on patient-related outcomes of these patients treated with...
So I would also like to ask you, what is the ideal time at which radiation should be started? Like in rest of the cases?
That depends. There were cases who were given NACT. In that case, we used to start radiation 6 to 8 weeks later. Actually, you will have to give enough time. You cannot just fill the expander at one go. You will have to gradually every week fill it for the skin to get expanded. And it takes at least 6 to 8 weeks to get a reasonable expansion. Then you deflate and irradiate. So it was not before 8 to 10 weeks that we used to start radiotherapy.
And is there any difference whether NACT first or adjuvant chemotherapy surgery followed by adjuvant chemotherapy?
So if adjuvant chemotherapy was given, we would actually be very happy because we had enough time for the expander to get expanded. If NACT were given, then you have very little time. In
that case also in adjuvant, if adjuvant chemotherapy has been given, did you change this thing expander with implant or continue?
No. In expander all the cases, expanders were irradiated. Implant was never irradiated.
Okay, so what is the target volume, and depending upon the pre-pectoral versus subpectoral, is there any difference in the delineation, contouring?
I said if it is subpectoral, you leave the expander. If it is pre-pectoral, you'll have to include the.
And tangential open fields versus IMRT, what do you prefer?
We did IMRT in all the cases.
Okay, and did you use skin bolus and
No.
no? And how much did you crop the CTV from the skin?
Even if you don't crop with a 6 MP beam, you automatically get cropped, and the skin dose is around 60 to 70% of cases. So we wishfully left that as such, and we did not use bolus.
Okay.
Risk of extrusion, in our paper, you will see that there were 20% extrusion.
So are these patients having more acute complications as compared to the ones who did not have implant?
Not really. Not really. The only precaution that we used to take is we used to tape the opposite breast away from the, reconstructed breast.
So do you have any experience with bilateral implant placement?
I think 3 or 4 cases in which we used to do a partial arc treatment.
So,
1 or 2 partial arc, or maybe 3 partial arcs we used to do.
So should we deflate on the contralateral side to avoid the exit beam? Deflate the tissue expander?
In all the cases during radiation, you will have to deflate it.
In the contralateral side, in bilateral cases of bilateral implants.
Which is not to be irradiated.
Which is not to be irradiated, which is not in our target volume for the contralateral side.
Oh, we did not do any such cases, so I don't have any experience.
Okay. So
we did bilateral malignancies, but not a reconstruction in a non-malignant breast.
Okay.
So have you seen?
No, I have not seen any ALCL. Maybe perhaps it was too early, and now it is the time because we are crossing 10 years. So now we expect one has to happen, unfortunately.
Right, sir. Thank you so much, sir.
Thank you.
We'll allow you to leave. Thank you so much, sir.
Thank you so much. I'm very sorry you have to go to hospital for some emergency. Yeah.
Sure. Thank you, sir. Thanks for joining.
Vaishali, ma'am, what do you?
Yeah. So, Dr. Anupma, we were actually on the question of slings. So, Dr. Ashok has already elaborated on that. What is your take on which patients do you choose for dermal sling or, for that matter, LD? Again, just your opinion.
So, slings actually is ideal for patients who have ptosis. So, large-breasted ptotic women, because then we plan a wise pattern. Skin incision so that there's skin reduction as well, and the part of the flap which we would have actually discarded, that is used as deepithelialized and used as a dermal sling to cover the lower pole. So ptotic patients are ideal for dermal slings.
So when you wish to go for such kind of reconstruction in a large ptotic breasted patient, your choice of incision is wise pattern?
Yes. Yes. And the patient has to be ready for the opposite reduction as well. Otherwise, it will look very bad because it will be a reduced breast.
So, do the patients agree to such a procedure in one go, or do they want to go in a phased manner?
So it depends. It's almost 50-50. Some of them want to do it together, and some of them wait for the cancer treatment to get over and then later come back for the opposite breast.
Right. Yeah, Chirag.
Ma'am. So I would also like to ask the plastic surgeons, maybe we can begin with Vipulnanda sir. So sir, are the plastic surgeons also a part of the incision planning when patient is planned for the reconstruction?
Yes, always.
Yes, always.
Yes, always.
Right, sir.
It's very important, yeah. In fact, I wanted to know what is the preferred site for a prophylactic mastectomy? I mean, risk reduction. What do the breast surgeons like? Inframammary or a periareolar or a lateral or what is the...
Anupma.
Yeah, so if you are doing a prophylactic where we are not going to check for the lymph nodes, then a periareolar or an inframammary is preferred. But if we have to go towards the sentinel lymph nodes also towards the axilla, then a periareolar racket-shaped incision going laterally towards the axilla is preferred.
Yeah. So what will be your choice of incision? I mean, what would you want the breast surgeon to do, sir? What will be the best incision in terms of cosmetic outcome?
I think this periareolar with a little extension laterally works well. I think it looks fairly neat. Inframammary is supposed to be nice and hidden, but in a small breast, it's not hidden. So I think a periareolar with the lateral extension, the way she described, I think seems a very aesthetic one.
But does it compromise on the vascularity of the nipple areola?
Not really, because you are sort of moving from there peripherally.
Yeah.
I mean, so that way the vascularity would probably be better than inframammary.
Right.
Because you're equidistant from both the edges.
And for inframammary, it's very difficult to go up till the superior pole and dissect out the breast for the mastectomy.
Right.
Like as you go higher and higher from the inframammary fold, the dissection becomes more and more difficult to reach the superior pole.
Unless the lady has the relatively smaller breasts.
Yeah.
Dr. Ashok wanted to make a point.
So the choice also depends upon what kind of reconstruction we do. If you are doing an autologous where we need to anastomose vessel either in the axilla or in the to the internal memory, inframammary crease becomes very, very difficult incision. But if you choose to do an implant-based reconstruction, I think inframammary gives an excellent cosmetic appearance. There is no visible scar for it. So what incision how you want to address the axilla, what reconstruction we plan will also determine where we want to put incision. A perioral incision with medial or lateral extension would be ideal for an autologous reconstruction. However, even with inframammary crease, you can put an additional incision in the axilla and go to thoracodorsal vessels to do an anastomosis if an autologous reconstruction needs to be done. But to reach inframammary or IMA or internal memory is very, very difficult.
Yeah, thank you, sir. Chirag.
So since Dr. Ashok sir had already spoken at length about the types of implants, I would not go too much into that. Any other of plastic surgeons who would like to comment upon the availability of the implants in India? Vipin sir?
Yes, there is a problem these days. So I think Dr. Ashok also mentioned this problem because we don't get too many implants, and a lot of thinking has to be made before ordering implant, because the company person will give 1 or 2 maximum 3 implants, and if you are ordering asking him to give a single implant, they will be reluctant because in aesthetic practice usually a pair is required, and in reconstruction mostly single implant is required. And the other thing is, sometimes you have to compromise with the correct implant size, and this has happened quite often with us, that sometimes, because most of the time we require a medium profile implant, not a very high profile implant, and in aesthetic surgery implants, in cases they usually need a high profile implant. So we have to compromise upon that. And recently, only 2 companies are available. Motiva and Eurosilicon have gone out of India. I don't know. So the other speakers, other plasticians might elaborate upon that. There is some issue recently on implant availability. Dr.
Unlike the orthopedicians who have a full trolley of.
So post-COVID, there has something has happened that initially expanders were in scarcity, and now implants have.
Ashok sir.
Yeah, so I put up the list of implants that are available. At least in Bangalore, what I put up, everything is available. And the second thing, to how to overcome the problem of mismatched or slightly mismatched implant is by doing a hybrid reconstruction. If you harvest LD, you can you can get away with using a smaller implant. So I'm taking a little more fat and muscle around the LD and use that. So this is how we overcome a little bit of mismatch with the implant that difficulty of procuring right size implants is being done for us.
Yeah. Dr. Ashok, there was a question in the chat box, in the Q&A box. Like you mentioned that you gauge the size of the implant with experience as well as by measuring the mastectomy volume. But in case if the patient has undergone, mastectomy sometime earlier and now you are going to do a delayed reconstruction, then how do you choose the size of the implant?
So that's very easy. What we do is called rice in the sock method. We allow the patient to wear a bra and fill the sock with rice. And ask them to put those socks into the bra and ask them what is comfortable, what size they want, which volume of that is comfortable for them, and measure that volume. That will give you roughly an idea, 600 cc or 400 cc or 350 cc. So in a delayed reconstruction, it is much easy. In direct to implant, it's very difficult to assess. So we need to talk to the patient what their expectation is, and not all the time you can match it to the opposite side. Right. And we need to tell them that this is what we can safely achieve, and probably undergo a secondary procedure on the opposite side. But in a secondary one, you can do that rice in the sock. That's what we do for aesthetic augmentation as well. So we can do the same thing here.
Right. Dr. Anupma, you wanted to make a point? Yes.
I wanted to make it clear that volume and weight is different. Yes. And we should remember that. So what happens is when we do a mastectomy and we weigh it, it's something like 600 cc, 600 milligrams. But when we want to put an implant, if you put a 600 cc implant, that's going to be huge for this breast. So there is a difference between the density of the normal human tissue, breast tissue, as well as the implant tissue. So you have to keep it in mind that the implant size you're putting is always going to be much lesser than the volume of the mastectomy, the weight of the mastectomy that you're taking out.
Right, absolutely. So these sizes which are available in the West, are they available in India? The implant sizes?
No, we don't have sizes.
You don't have. Okay. No. So I heard somewhere that in Tata Memorial, they use a glove filled with saline to get a rough idea about how to choose implant. Do you use the same idea?
We don't actually. We weigh the mastectomy specimen, take an idea, and then if you're doing a hybrid reconstruction with LD, we visualize how much the LD is going to give us, maybe 100 or 150 or even 180 milligrams, and then base the implant size on that. Always remembering to keep the base plate measurement in mind.
Yeah,
that is very important. When you remove the mastectomy specimen, you should take the base plate measurement from the base of the mastectomy specimen.
Agree. Totally agree. Thank you so much. Dr. Chirag, I think we can take a question or two and then maybe it's the time to wind up. So please go ahead.
So she underwent a LD with an expander placement at the time of mastectomy and then followed by exchange with an implant after completion of the RT. We've already discussed with the radiation part. These are the few pictures of the reconstruction of this patient. We've already discussed this question. So coming to risk reduction surgeries in BRCA positive patients. So what would be the recon planning? I would start with Vipul Nanda, sir. Am I audible?
Yes, you are. Dr. Nanda?
Maybe we can go to Dr. Mahendra, sir. Yes.
Yeah.
Dr. Vipin, sir.
Do you want to know about the...
In BRCA positive patients who are going risk reduction surgery on the opposite side, how would be the recon planning for, the...
It would be same. I mean, there won't be any difference. See, ideally, Yeah,
Considering that the one breast is considering that one breast may require the radiation and the other breast is just going up prophylactic.
Yes. So again, see, bilateral breast reconstruction, autologous, and we have to discuss about autologous or reconstruction or hybrid mode with LD plus implant. So it will be same, almost same. Only thing is we might, my choice will be first autologous, and the second choice will be if patient is not ready for bilateral DIF, because doing double free flap has its own added risk. So if patient doesn't want to, doesn't agree for that, then we might think of bilateral LD with implants. Obviously, the side which is will be irradiated, I'll prefer to put a expander if available.
Ashok, sir.
So these patients fall into two categories.
Sure.
BRCA1 who have got a malignancy on one breast and they have been diagnosed to have BRCA and they've undergone. So for such people, my choice would be to do bilateral DIAPs and irradiate the side which is having the malignancy. In terms of symmetry, in terms of aesthetic outcome, it gives excellent because we are taking one half of the abdomen and matching it to the other side. So that way it gives good results, and radiation is not a problem. But in patients who are coming for complete, somebody in the family has been diagnosed and malignancy, and through that they have found out that they are all BRCA positive and they want mastectomy. I have no problem in offering them implant-based reconstruction with subpectoral implant placement with an ADM or a mini LD that covers the opposite side, or even using serratus fascia covering that. So subpectoral is possible in patients with who are not having malignancy and don't require radiation. That's how I would think in terms of reconstruction.
So I think in the paucity of time, we will have to wind up and we'll request Dr. Arun Goel sir to give us the parting comments. And
I think Anupama wants
Dr.
to
Anupama wants to make
yes,
a comment. So yeah, we would.
Yeah. So just one last point, something we've not discussed is something known as scarless LD. So, this is without turning the patient, without making an incision on the back, we can still harvest a portion of the LD, swing it forward and cover the lower pole of the implant when the implant is placed subpectorally. So what I have realized, we've done over 30 cases now of this technique and it's given very good results. The pain at the back is less. There is no incision site at the back. And this is especially good for the BRCA positive ladies who are undergoing bilateral prophylactic mastectomies also. So this is something which I think needs to be explored much more. It was described a few years back by Dr. Mark Lee of Australia. And I really feel this technique has been underutilized. And I have published on it and I have videos. So if anybody wants to see, can see. But it has given excellent results. So mastectomy with a scarless LD.
Thank you, Dr. Anupama. That was a really nice input. Unfortunately, because we have already sort of coming to 2 hours of the event, so we would like to stop here. The topic is so interesting that we can keep on discussing for another 1 hour and still not be through with it. So the important thing is that breast reconstruction is in India, at least post-mastectomy reconstruction is something in a very early phase of acceptance or demand. So it's something over the coming years we are going to see more and more demand from the people, more and more availability by the oncologist being comfortable with offering primary reconstructions, because probably primary reconstruction is the way where maximum acceptance is there, convenience is there. So over the coming decade or so, we'll definitely see much more number of cases. So we need to keep on discussing as more and more experience gets accumulated. So with that, I would like to thank Dr. Ashok for a wonderful talk and all the panelists for a wonderful discussion, and thanks Dr. Vaishali and Dr. Chirag for handling the panel discussion quite well. And again, my thanks to Mice Ideas for doing a good job of handling the logistics, communications and all. Thank you very much. And we will be back like Terminator, we can say. Thank you.
Thanks to all of you. Thank you so much.
Thank you.
Bye.
Thank you.